turn on next speak, please.
Good evening, Tolagele.
Good evening, Dr. Kinoshi. We are ready.
We are ready. I think you can admit all. Good evening, everyone. I think we've got about almost 200 participants now. It's 6 o'clock exactly, and I think it's time to start our weekly Clinix Health Group webinar. We've been doing these webinars for some time, for about, I think this is the 4th or 5th year since 2020, and I think I'm happy that they are continuing still, thanks to the board and EXCO of Clinix Health Group, who are sponsoring these webinars. And we want to thank you all who have managed to log in. Today, we are having one of ophthalmologists. We have one of the young ophthalmologists, I must say, we have introduced in the country, and we are proud to have Dr. Comfort Fakude. Dr. Fakude is a product of Wits undergraduate. He did his MBCHB at Wits. He did his M.Med in ophthalmology in UP Steve Biko Academic Hospital, University of Pretoria. And he passed with flying colors from there. And he is now newly appointed ophthalmologist in Tembisa Provincial Tertiary Hospital. I must say he's the only ophthalmologist in that hospital, and Dr. Fakude, I'm certain that you will be a boon to the patient population, that the millions of people that Tembisa Provincial Hospital is serving, because it has such a huge responsibility. And I'm sure with you, they're in good hands as far as ophthalmology is concerned. Dr. Fakude has got experience in various procedures, not only the topic of today, but he's also been very active and keen in the diabetic eye, in the trauma to the eyes, but he's also had experience in retinal surgery, in transplants, ophthalmic transplants, including corneal transplantation, since the Biko Academic Hospital is one of the few hospitals in the country that offer corneal transplantation, both private and public. It's not. It's a service that is not offered everywhere. And I think so. He was fortunate to have this experience, and he'll tell us today. The topic that he chose today is cataracts, the diagnosis and management of cataract surgery, a guide to cataract diagnosis and management. Over to you, Dr. Fakude. Dr. Fakude, you can unmute and go on.
Yes, thank you very much, Dr. Kinoshi, for the wonderful introduction. And thank you again, Clinix Group, for inviting me again to present in this platform. I must mention that my professor, Professor Makunyane, was supposed to present this lecture. So this is a collaborative work between me and her. So I'm just stepping in to do that, and I'm happy to do that in this platform. I understand that we have a lot of professionals, especially doctors, optometrists, and other specialties, and I hope I'm well able to interest all of you because this is we can call it the bread and butter of ophthalmology, which is cataracts, when we do cataract surgery, but nevertheless, I just want to start here with this slide as we start this presentation. Anyway, we're going to look at this is an overview of how we're going to look at this presentation, introduction, epidemiology of lens opacities, and classification, the types of lenses, and then we're going to look at then at the end and all the subheadings under that line, and then come to the conclusion of the presentation. And as we start now, yes, I wanted to interest you a little bit on this particular slide concerning cataracts in the country. The IAPB, pretty much they say for every one bilateral cataract patient, there is about 4 other with unilateral cataracts. You know what I'm saying? So if you find a patient who is bilaterally blind, both eyes, you are most likely that there is 4 others as well that have a unilateral cataract. Now, these are gross stats, not real stuff, but this is something that I've asked around, and from where I'm working with the South African, where I've been working with the South African National Council of the Blind. In Genfirst, at some point in time, I think that was 2 years ago, there were about 6,000 people waiting in that area. So the Sekhukhune area, there's over 4,000 in Genfirst Hospital that are waiting to be operated, And I must mention as well that in Tabazimbi, we had currently, recently, we operated, that is like 2 weeks ago, we operated 190 patients in 4 days between myself, Dr. Ngatane, and Dr. Sibomane. And we still have left a lot of people, And so in that area of Limpopo, there's hospitals like Butlokwa, or people that come to Tabazimba are coming from Butlokwa, Elim, or Dendal, all these places, to just get the help in Tabazimba. So they have to drive hundreds of kilometers to get help because it's not given in some other places. The waiting list in Limpopo is estimated to be above 23,000 people waiting to get cataract surgery. I spoke to one of my friends, a medical officer in Mankweng. He says there's about 44,500 cataracts waiting to be operated, So in KZN, probably over 10,000, Eastern Cape, over 23,000. These are just rough estimations, not the actual number that is there. Gauteng, over 16,000 people. Free State, maybe over 10,000. Northwest, over 8,500, So these are cataracts that our people have, and we can't seem to reach them. In Northern Cape, we have very hot climate there, lots of UV light. In Kimberley, Namakwa, Francis Bart, Springbok, these are places that have a lot of cataracts, and I think others, even when they hear that the Bureau or the South African Council of the Blind is there for cataracts outreach program, they drive over 400, 200 kilometers to get help in another place, because they have a very huge province, So anyway, so I want to mention that when I was doing my studies, would come in the next slide, my dissertation, it is mentioned that in South Africa, there's close to 300,000 new cataracts every year. So you can imagine, since COVID times when we were not operating, how much that backlog has increased. These numbers did not even probably reveal the true state of things. You know what I'm saying? So it's very important for us to take cataract disease very serious. This is a preventable blindness that is very simple to treat. And yet we find ourselves struggling in the public sector to address the crisis. It is a crisis because people who have cataract studies have shown that they are depressed. And if you're depressed, you're most likely gonna kill yourself. Most likely, there's a lot of consequences. Now you must be on medication. Now you're not employed. Now, there's a lot of things. Also, the burden of death can go up because people can fall, old people, fracture hip, that can be operated. And then and from there, life declines into misery. And our old people, beloved people, they die in misery because we just can't reach the gap. Many, I am certain, that have died with cataracts, and it is something simple, so simple to solve. And yet we can't solve it. We can't seem to get around it. There's a lot of challenges we have, maybe mismanaging of funds in the public sector, all sorts of things. We have no resources. Needs to address the burden, to work properly. And the eye is a very complex organ that needs machines, unfortunately. And we need to spend on these things. We need proper machines, we need proper equipment to be able to do this work efficiently and perfectly. So, so anyway, moving on. Cataract is, as we've mentioned, these are some of the things I've mentioned. So 26% of the world blindness is due to cataract blindness. 26%. That's a huge number. If you take 26%, and a fifth of that is being in Africa. There was Vision 2020 that focused on eradicating blindness by 2020. What happened? We are still here sitting with a big backlog. Now we have Insight 2030 that can only address 25% of that burden in the world. And you must know that the massive population that are suffering with this, it's us, the developing countries, Africa. That's where this problem affects us. We can't develop properly because the skills are sitting with blindness. The young people with diabetes and cataracts are sitting at home. They can't work because also we can't operate them because there are no funds, there are no funds, there are no resources, and all these things. It's a lot. So obviously, age-related cataract is the most common type. So colleagues like general practitioner, optometrists, physicians, rheumatologists, dermatologists, gynecologists, etc., they play a key role in early diagnosis and referral. And we hope that at some point we would be able to address the problem as ophthalmologists, or maybe medical officers in the field. So looking at epidemiology, we've mentioned some of these things. So over 94 million people are visually impaired due to cataract. That's a huge number. And a big number of that it's here in the continent. Obviously, they can be congenital, it can be acquired. We've got obviously risk factors which are non-modifiable, increasing age, genetic predisposition, female, gender, high myopia. Modifiable causes would be, or risk factors would be tobacco, UV exposure, diabetes, hypertension, drug exposure, ocular trauma, and surgery. These are other modifiable things that we can do. Cataract surgery globally, there's over 10 million cataract operations per year that are being done. But Africa, less than 500 surgeries per million people are being done. You can see we're not doing much. There's a huge burden on our side. So it's very important for us to address this. So looking at lens opacities, just a big more on the academic side, and the acquired ones, age-related, traumatic. I'm sure we know that South Africa is one of the most violent countries in the world. So there's a lot.
Dr. Fakude,
Yes.
if I may interrupt. Yes, my apologies for the interruption. I think the
Dr. Kinushi, can you hear me? I can't hear you. I'm not sure if you can hear.
Yeah, I see that there's some audio problems, and some people in the audience are complaining that they can't hear well. It gets distorted here and there, but I think it's a bandwidth problem. So if you could just switch off your camera whilst you are presenting, and then during question and answer time, you can put it on again. But if maybe the bandwidth will improve. Yeah, okay. Thanks. Sorry for the interruption, but you can go ahead, Doc. Bye.
Let me change as well.
Yeah, no, but no, I think it was just the
camera.
Just the camera. But I think the volume is fine. We can hear you quite well. I can hear you quite well now. Thanks.
No problem. Okay. Hope they can tell us if there's still the problem taking place. Okay. Let me continue here. So, as I was mentioning, maybe it's worth going back a little bit to that introduction that I spoke about. You know, to say that there's close to 300,000 new cases in South Africa every year caused by cataract. And we have massive backlogs. And also to mention that the other specialties like general practitioner, optometrists, physicians, rheumatologists, dermatologists, gynecologists, etc., they play a role, you know, in early diagnosis and referral. And I'll mention later why am I mentioning all these specialists, you know, in this space. Why am I talking of a physician? Why a rheumatologist? Why a dermatologist? What is it that they would do? What are they doing that can cause a cataract? Because I'm mentioning them intentionally, knowing that they are probably doing something in treating patients that as a side effect causes a cataract, if we can put it that way. You know, we spoke about the stats. You know, I'm just going to skip this slide and go just to the next one. Next slide. So now the acquired cataract pretty much could be age-related, which is the most common, which there's different types thereof. There's trauma, which can be blunt trauma, penetrating injury, surgery, radiation, chemical injury, electrical injury. I'm mentioning this because this is, we as a violent country, this is the thing that we suffer from. Secondary causes as well, we have chronic uveitis, which we speak of this because we have conditions like SLE, rheumatoid arthritis, you know, that are autoimmune diseases that can spill over into the eye. You know, we've got high myopia, we've got obvious hereditary fundus dystrophies. Those are other things. And we've also have got secondary to systemic diseases. This is where we all come in together. Diabetes, you know, it's the most common disease. Other ones, myotonic dystrophy, pseudoexfoliative syndrome, atopic dermatitis, that's where the dermatologist comes in, hypocalcemia, physician, neurofibromatosis, galactosemia, Wilson's disease. This is just some of the things that we can cause a cataract, how we acquire cataract as we move along. You know, so as we've mentioned, what is a cataract? Pretty much obvious. A cataract is when the lens becomes white. You know, the lens is that structure that sits between the pupil, that sits in the pathway of the pupil, in the space that is formed by the iris. That's where the lens is, and it can be subcapsular. If I say subcapsular, means that the lens itself has a capsule, anterior capsule and posterior capsule. You know, just like the lung has a pleura that covers the lung, you know, in front and the back. You can say anterior pleural space and posterior pleural space. So even here with the cataract, we can have anterior capsule, posterior capsule. So we find the cataract, it can start subcapsular, anteriorly and posterior, you know. So subcapsular is directly under the lens capsule, and posterior capsule also just posteriorly under the capsule. You know, so there's different. Then we've also got nuclear sclerotic, which is the center of the lens itself. You know, so this is an exaggeration of normal aging change. It can have a yellowish hue due to euchrome pigment, and then also advanced cases can even appear to be brown or black in color. So this is just how we classify them. You know, so basically the hardening nucleosclerotic cataract is when there's hardening and yellowing of the central nucleus, etc., etc. And then this is when this happens in an old patient, then they can start enjoying to see things closer. That's why we call it second sight, but this could be caused by the starting of formation of a cataract. You know, so we are well placed because we are able to put the patient in a slit lamp and start examining this cataract. So there's also what we call cortical cataract, which is right at the periphery, at the cortex of the cataract. So the cataract is as a capsule, it has the cortex, it has the nucleus. So the cortex is more the softer part of the cataract. And people who, when they drive at night, suddenly they notice that the bright lights they seem to be causing a lot of problems and glare is because light is reflected from those spokes of the cataract. So when that happens to you, maybe it's time to go see an optometrist, ophthalmologist, so can examine that cataract. You might find that your problem will be as simple as solved. So this is what I'm trying to say that to you. So now moving on, obviously there's degrees of cataract maturity where you can have a immature cataract, it's slight opaque, mature is white, completely white, hypermature becomes shrunk, the capsule becomes shrunken. We've got all types called Morgagnian cataract, whereby the nucleus is the only thing that remains and sunken, and the rest of the cortex become liquid. So these are different things that we see in terms of the cataract itself. In my mind, I have this battle to say, am I presenting to ophthalmologists or general practitioners? But I find that I present to everyone. So some things are going to be too detailed, some things maybe not as detailed, but I'm going to try to cater for everyone. So now cortical cataracts, these are opacities in the outer layers of the lens forming spoke-like patterns, as we spoke. So they cause glare, light scattering, and difficulty with bright lights, as we've mentioned this. Now, we talk about those are age-related cataracts. Now, when we talk about traumatic cataracts, which could be caused by contusion or perforating or penetrating injury, we know this. So this can be caused by a lot of things. So there's different ways. So when there's contusion, when we look at the slit lamp, we can have signs like Vogel's ring, like as you can see, this ring over here is because now there is imprints, or there's the lens fibers. They become necrotic because of the contact with the iris. Nevertheless, we continue. Traumatic cataract can be caused by blunt trauma, which can cause acute or delayed onset of lens opacification. So it's very important as you examine patients to ask them, have you ever been hit on the eye? They can say, no, maybe 10 years ago or 5 years ago. That could be the onset of the problem. So it's very important to know this information. So moving again, as part of trauma, obviously we can have also rapid globe expansion, like dislocation and subluxation of the lens. We can have disruption of the zonular fibers as we are hitting the eye. So this could affect a lot of things. So obviously this poses challenges to us as ophthalmologists of how we're going to treat the eye. If now the lens, as we know, it is suspended by ropes, which we call zonules. If now the zonules now are detached or they are weak when we do cataract surgery, most likely the lens might drop to the back of the eye, and that could has its own complications. So taking history is quite important, and also not even if a patient sometimes doesn't really have an eye, something that they complain about after they've been hit in the eye, you might find that later on they might develop even other problems called like retinal detachments because of that trauma history. So it's very important for us to know the patients at risks. That's why we're speaking about trauma and cataract surgery. So now we also have other procedures that can cause traumatic cataracts will be intraocular procedures when we do pars plana vitrectomy in trying to solve a retinal detachments. Because as we move the instruments inside the eye, we can touch the lens. Just touch it, not even hitting it, but touching it, that can cause a cataract. So these are some of the things that we do ourselves. Trabeculectomy also, that's when we're trying to solve a glaucoma problem. There's high pressure, we're causing, now we're performing trabeculoplasty or trabeculectomy, where we're cutting a valve on the trabecular meshwork to let aqueous flow nicely. We can also damage the lens there, So even when we do penetrate keratoplasty, what do you call it? Corneal transplant surgery. That's what is called penetrating keratoplasty. Or other procedures like DSEC, because we are too close to the lens. If we're not careful, we can cause this problem. Also, we have also intralenticular foreign bodies, so foreign bodies perforate the cornea, anterior lens capsule, and lodge within the nucleus. So this can cause also a cataract. So the lens is quite sensitive, so you kind of have something foreign landing there. Also radiation, if we're going to give radiation close in the head, we're most likely going to develop a cataract later on. Maybe not immediately, but over a period of time. We have ionizing radiation, time to change to cataract depends on the dose and patient's age. X-ray range cataracts after two grave fraction exposure. So all these things they are risk factors to the formation of cataracts. Infrared radiation. Those who those who work by using glass blowers, they're also at risk of cataracts. Ultraviolet radiation. In as much as we bask in the sun, we must have shades on to protect our eyes from that, because that can cause a lot of problems. Chemical injuries, we know this, whether it be alkaline injury, those are also can cause cataracts. Metallosis, where we talk about siderosis bulbi, iron-containing foreign bodies, this can happen. Chalcosis, bulbi, that's another thing where there's copper deposit in the descemet membrane. You can see in those pictures there, the deposit of copper there, with causing sunflower cataract, with yellow-brown pigment deposit in the capsule. Also have what electrical injury, which it causes protein coagulation, where, and causes therefore cataract formation. Initially the lens vacuoles are normally found in the mid-periphery, so, but as the time progresses, you find that now the whole lens is affected, and the patient now start complaining of poor vision. Sometimes the cataracts could be very mild, but you'll be surprised there's a number of the symptoms that it can produce to patients. Now, coming now to this other one, chronic anterior uveitis, especially now bringing in people who are treating chronic diseases like rheumatologists. You'll be treating an SLE disease, which can also spill over and have a type of uveitis in the eye. Uveitis, pretty much, it is inflammation of the uvea. What is the uvea? The uvea is the iris, the ciliary body, and the choroid. So the iris is too close to the lens. Therefore, that inflammatory process will affect the eye. So those who are rheumatologists, you most likely your patient say, now I can't see very well. It's not because they need glasses, it's because probably they have a cataract. So refer them to an ophthalmologist for them to review them and see what's happening. Is it because there's a uveitis, which you can, if we intervene very quickly, we can solve the problem. Sometimes when people are rheumatologists, they use a lot of steroids in some early phases to arrest the inflammatory process or the spike of that whole severe inflammation. They use a lot of methylprednisone, so that also causes the cataract. So it's very important. So just coming in here, even people who have eczema, they're using creams on the skin, not because you are drinking the prednisolone oral, but just putting creams on the skin. That is a risk factor to cataract formation. Even our own drops, when we give steroids into the eye, the risk for cataract formation. So all forms of steroids, whether it be topical, be creams, be whatsoever, they pose a risk to the formation of cataract. So it's very important for us, therefore, to know that our patients, if it's been a while, just send them to an ophthalmologist or optometrist for them to be reviewed. So you can see in this picture, these are, we call them anterior synechia, where there's adhesion. Pretty much this is just adhesion between the iris and the lens. You can see now, even here, the patient won't see because now the iris is stuck on top of the lens. So we need to do cataract surgery. So it's very important for us that when we talk about secondary cataract, like caused by uveitis, how long has it been? How long has the uveitis been there? History of recurrent uveitis, all these signs. Of course, when we must do the surgery on our side, at least as ophthalmologists, we know we need to be aware that the patient is no longer active for at least 3 months for us to operate. Because if we touch that eye, there's going to be problems. The uveitis is going to come back, and it might be even worse than it was before. And obviously, this poses to us a challenge to solve the problem, or not necessarily a challenge. Yes, a challenge, but we can prepare for it by planning for the surgery properly. So nevertheless, prevention is better than cure. Or I would say all those who are rheumatologists or physicians who have their patients on steroids, rather refer them once a year to just have a look, to be reviewed by an ophthalmologist to check if everything's still okay in the eye. So now we also have cataracts caused by ocular disease, like high myopia, those who are very short-sighted. So you're at risk to have a cataract. So sometimes when you keep changing glasses, maybe it's not the glasses that you need to change. So go see an ophthalmologist so that you are able to be helped properly, you know. So let alone the fact that when those who have myopia, they're also at the risk of developing glaucoma. That's also another thing, another reason for you to go see an ophthalmologist if you are short-sighted. It's not just for glasses to the optometrist. You must see an ophthalmologist so we can review nicely the back of the eye, look at the lens and see if there's any other problem that are taking place over there, you know. And so now coming back now to other causes, ocular causes of cataracts, acute congestive angle closure, where we've got now this sudden pressure in the eye, which can cause what we call glaucoma flecken, which is small anterior grade wide subcapsular or capsular opacities in the pupillary area. You know, this is focal lens epithelial infarcts, you know, that you find, especially in acute congestive angle closure. Anyways, I think I will leave that to the more detail things necessary for you. Anyway, so now we also have other cases, which is ocular cases, but associated with cataract, hereditary fundus dystrophies, patients who have retinitis pigmentosa. This could be the diagnosis that the patient has. We must also be aware if that patient starts complaining of poor vision, could be that now they've developed some kind of a cataract. You know, other conditions like Leber congenital amaurosis, gyrate atrophy, Stickler syndrome, you know, the posterior subcapsular lens of opacity. No, but that means if you're not really properly trained, or you know, and you're not looking properly at the lens, if it's subcapsular, especially posterior subcapsular, you look at the patient straight, it looks like there's no cataract, but if you properly examine the patient under the slit lamp, you see that it is there, it just is posterior subcapsular. So it's very important that the patient is dilated properly and examined properly for that if there's no cataract. Now coming back now to cataract secondary to systemic diseases, most important disease is diabetes mellitus, you know, where we have hyperglycemia, which will cause an elevation in blood sugar that also translates to elevated aqueous human glucose, which then gets absorbed by the lens. So what that happens now, this glucose is metabolized to sorbitol. And then what that does, sorbitol now, because sorbitol it's a substance within the lens now that pulls, then we get secondary osmotic overhydration of the lens, you know. So now, so we have now increased non-enzymatic glycosylation of lens protein and greater oxidative stress from alterations in lens metabolism. But maybe what is important that when now the lens is overhydrated, that's why patients who are newly diagnosed with cataract who are diabetic, they say now they can't see, you know, suddenly they can't see or they're short-sighted. It's because now the lens is too bulky or too lumpy, means therefore now the refractive index of the lens has changed. Now the lens is bending light more, causing the patient to be short-sighted. Now they can't appreciate distance view, but that is all because of the disease and it being uncontrolled. So it's very important for physicians, therefore, to control that disease process, because we also, you know, this will impact on lens clarity, you know, as we've mentioned already here, you know. So this we've mentioned, just more details. Yeah, so diabetes then can cause in a young patient snowflake cataract. It's not a common thing, you know. So can be bilateral rapid onset subcapsular lens changes, where we find multiple gray, white subcapsular opacities in the superficial anterior and posterior lens cortex. You know, so these vacuoles or spaces and clefts form in the underlying cortex, followed by intumescence and maturity of the cortical cataract. It developed. So, but pretty much what we can say that now, cataracts in diabetics, they develop early, you know, compared to those who don't have diabetes, you know. So it's because of this continuous process of absorption of fluid into the cataract, and you know, that back and forth because of lack of control of the disease. So this can cause cataract and blindness, you know. So they say here in this, it says now around 1 in 5 people who undergo cataract surgery, have diabetes. That's how much the rise of diabetes is attacking the population in the world. And therefore, because of that, also the cataracts are forming more and more and more. So now this is the presence of diabetes, diabetic macular edema prior to cataract surgery is associated with worsening of the edema, especially after the surgery. So it's very important, therefore, for us to make sure that we're well able to examine the patient properly, especially if we're going to operate them, those who are diabetic. To be a very, it's a catch-24 or 22 thing when you find that now the lens itself is white, that you can't see at the back of the eye, and the patient also has diabetic macular edema. And we know that if you operate such a patient, that edema will worsen. And even if you've done perfect surgery, the patient will continue not to see properly because the macula would have been more swollen because of the surgery itself, the nature of things. Nevertheless, it's just things, a word for maybe for those who are operating such cases. Other conditions that are systemic and also associated with cataracts are myotonic dystrophy, which present with the main complaint of delayed muscle relaxation, ptosis, facial muscle weakness, and cardiac conduction defects. And there's all these other things. But the patient here will present with that kind of cataract that you see there. It's like a Christmas tree cataract. Maybe you might not appreciate it because as general practitioners, as other specialties, you don't have slit lamps to look at this. So, but for us as ophthalmologists, would appreciate this kind of picture, and associate with that. Maybe one important condition that we must note of is pseudo exfoliation syndrome. It is very easy for ophthalmologists to pick it up because we can actually see the fibrillogranular material on top of the lens. As you can see, that it's like this flour-like powdery material that sits on the lens. It can be pathophysiology. It's like unilateral or bilateral disorder of advanced age and increased UV exposure. So you can see that's why there's so much cataract in those areas of Limpopo, and most of them as well. Sometimes we cancel them in the tours or in the campaigns to do cataracts because they have pseudo. We're going to create more work for the retinal surgeon who must go now and fetch that lens. So anyway, this is a matrix of fibrotic material. It's deposited in this pseudo-exfoliative material. It's deposited in many organs, the lungs, the livers, So, but then we can see it in the eye easier because we're looking at it directly with the slit lamp, So not just that, also the pseudo-exfoliation, also this material can also clog up the trabecular meshwork and cause glaucoma. So that's also something else, So what else does it do, this pseudo-exfoliative disease? We find that there is also papillary margin iris atrophy in this disease. So that's why you find that patients who have pseudo-exfoliation, also they dilate poorly. The eyes don't dilate as easy. There's also anterior iris pigment deposition in the same setting. That's why I think one friend of mine asked me, all these patients that they operate, there's all this pigment. Yeah, so that's the answer. The patients probably have pseudo-exfoliation. There's all this dispersion of pigment in those eyes, not because they have uveitis, but because probably they have pseudo-exfoliation. The weak zonules and then the lens subluxes, or it denses, the lens denses within the eye. And we've mentioned as well that the clogging of the trabecular meshwork causes glaucoma. And so in cataract surgery, there's a risk of this lens dropping into the back of the eye. But anyway, that's not a problem of the general practitioner or any other specialist, but the problem of the ophthalmologist to anticipate how to deal with the problem. Other diseases, coming to dermatologists, atopic dermatitis. Also, the patient will, apart from the fact that you might be treating them with steroids at some point, but the disease itself is associated with this anterior or posterior subcapsular opacification. So it's very important that when those patients complain of poor vision that you must know there could be cataracts. You must involve this ophthalmologist. Also, hypocalcemia. Cataracts develop in any condition that it causes hypocalcemia. These causes will be idiopathic causes, hypoparathyroidism. So this will cause bilateral punctate, iridescent opacities in the anterior or posterior lens capsule. This is for us to look at it and see exactly where it is. Also, other condition is neurofibromatosis type 2. Also is associated with early cataract in 60% of patients. So these are some of the things you will refer the patients with these conditions to have a review with the ophthalmologist to check what's happening. Other systemic conditions, galactosemia, which is an autosomal recessive disease, inability to convert galactose to glucose. So the galactose accumulates in body tissues. So in the ocular, the nucleus and deep cortex opacification will cause the oil droplet sign. So you can see that if you look at it, it's almost like there's oil in the eye, but it's because the nucleus has opacified and the surrounding cortex is clear. So it gives like this oil droplet sign. That's what it is. Other one is Wilson's disease, which is also an autosomal recessive disorder of copper metabolism. You can see there the Kaiser Fleischer ring, which is the blunt discoloration of the descent membrane. This is a descent membrane, which is the the fourth layer of the cornea from going posterior from the front. Anyway, so moving forward. So we also have the psychiatrist. Why is the psychiatrist also must worry about cataract? Is because he is prescribing phenothiazines, the antipsychotics. It's not the psychosis that is causing the patient not to see. We don't have to dig deeper and deeper. Say, maybe now they're having another delusion because they have schizophrenia. But it could be that the phenothiazines are causing a cataract. You see what I'm saying? So that's how cataracts are so broad and affect many spheres and many disciplines. So refer to the ophthalmologist, especially if you're prescribing phenothiazines, so that we can have a look at it. And so also we'll talk about corticosteroids drug. These are steroids, we've mentioned them earlier. There's a dose-dependent long-term use of oral, topical, or inhaled appeal of asthma. Now they can see well. Going back to the optometrist, prescription the same, patient is complaining, refer to the ophthalmologist. Maybe need a dilated fundus examination to properly look at that lens and see what's happening. This is associated with the posterior subcapsular opacification. Also, there's also that ocular hypertension, which is high pressure because of the steroid. You know what I'm saying? So steroid use can cause high pressure in the eye, which can over long-standing period damage the nerve. So it's very important that when we're using steroids, just have the patient go see an ophthalmologist. But yeah, man, you're on steroids for some time. I'm happy with your control, but just in case, just go see the ophthalmologist. Let them look at you. Let them look at the disc. Let them do OCT. Let them examine further than that, because in solving one problem, you could be creating a deeper problem that could not be solved. Because maybe you didn't know the consequences and complications of some of these things. Other ones is amiodarone, which can deposition in the anterior cortical axis. Though this picture shows more cornea deposition of amiodarone, which is the cornea verticillata. This is just the picture in the cornea. But as we've made, it can also cause optic neuropathy, amiodarone. So you must know these drugs. I guess those who might be prescribing this drug maybe could be cardiologists. So very important to know these things yourself. Myotics, these are topical anticholinesterases for glaucoma. We really use them, but there are studies that are looking into that, especially to solve issues of accommodation and reading, etc., at low doses. So anyway, that's something that we must know. Especially, I guess people will know about these myotics is ophthalmologists. I don't think, yes, but anyway, myotics, the drugs that constrict the pupil, topical ones can cause the posterior, cortical, and nuclear cataract. Other ones, the physicians, general practitioner, the statins, and Lipitor, those drugs. There's conflict studies, both a risk factor and a protective factor, but nevertheless, that's where we find ourselves. You know, we also have tamoxifen. This involves the gynecologist. No, this is the surgeon, because he's solving breast cancer, or whoever solves it, whether he's an oncologist using tamoxifen, you could be causing cataract. You must know. Allopurinol, you are solving gout, but you could be causing cataract. So know this one. Modafinil, you know, anti-narcolepsy drug, you know. So that's also important to know. The general practitioner or all specialists, mostly diazides, antihypertensive drugs associated with posterior subcapsular. Everybody is involved in this screening of cataracts themselves. Anyway, so now just coming here, winding down to the end, how therefore would you approach cataract? You know, how do we get to that, to diagnose it? History is very important. Visual complaint. What exactly is the problem with the vision? Is it blurred vision? Is it there all the time? Do you wake up with it? Is it misty? Is it glare? Actually, I can't drive at night, man. There's a lot of this. Have you ever had previous surgery? You know, because glare as well can happen because you have put a fancy lens in your eye. You know, it's okay, but you know what I'm saying. So these are the things, a detailed history of getting to know what caused this. You know, are you short-sighted now suddenly? You know what I'm saying. These are the second side of adulthood. Maybe you're having cataract. We spoke earlier about that the nuclear sclerotic cataract. You know, so this is very important. Now others can't even appreciate. No, man, you know, red doesn't look as red as it used to be. Oh, yellow is not as yellow as it used to be. This is contrast sensitivity problem. So the cataract is blocking the penetrance of light into the eye to be assessed by the retina. So it's very important, therefore, to ask properly. Not just, oh, we have blurred vision. Okay. Next question, you know, ask exactly what's wrong with your eyes. Eh? You know, maybe he just lost his contact lenses. You know what I'm saying? So it's very important to ask these questions. Systemic condition, diabetes, you know, asthma, rheumatoid arthritis, SLE, TB, which obviously the drugs themselves, maybe not the cataract, don't mention there, but we know about ethambutol causing optic neuropathy. Very important things. Eczema, because of the steroids of use, autoimmune disease as well, because we're using steroids there. Allergies, steroids, VKC, lots of steroids, which is venal keratoconjunctivitis, and AKC, atopic keratoconjunctivitis. You know, are they smoking? Are they drinking alcohol? What's their lifestyle? You know, all those things, they predispose people to formation of cataract. Poor diet also. You know, our people in South Africa are suffering because they don't have funds and all these things. All these, they inflate the burden, the crisis, the burden of cataract in the country. You know, so drugs, we've mentioned a lot of drugs already, you know, especially, you know, maybe drugs, you know, also they're important for us to know what kind of drugs you are on. You know, the urologist, you might think that he's far away from the eye, but if he's using alpha, you know, those drugs that help to release the spasm in the prostate, those are a problem for us because the iris is going to be floppy. It's going to be a very nightmare-like procedure. So for us, it's very important to know these things so that we can stop the treatment, so be able to do proper surgery to sort of prevent or to anticipate the problem. Anyway, you know, so we also have common symptoms. We've mentioned them as we went along. You know, coming here. Now, what else are we going to be considering ourselves on our side as ophthalmologists? You know, we just have to assess the visual impairment, its impact, functional impact, and also identify risk factors, especially the one we've just mentioned about diabetes, anticoagulation. Why talking about anticoagulation? Because if now we are operating and we're going to do a particular procedure, maybe let's say small incision cataract surgery. When we start operating, there's a lot of bleeding that's going to take place because maybe you're on warfarin, maybe it's above the acceptable range of clotting, INR above 3.5. So it's very important some of these things to know that, you know, so that we can stop the treatment a week or so before the procedure itself. At least that part will involve us as ophthalmologists to know these things. Ask about aspirin, maybe to stop it a few days before we do the procedure. though most of our operations, if we're done right, we have minimal or no bleeding at all, especially if you're doing phaco emulsification and cataract surgery. There's no bleeding there. Why would there be bleeding? Because you are doing an incision on the cornea. But anyway, we will come to those procedures as we close up in a short while. Anyway, and so also medication, as the alpha blockers I mentioned, the risk of floppy iris syndrome, which is one of the most terrible conditions to deal with when you're trying to do cataract surgery. Every time you're trying to do the procedure, the iris just jumps and blocks your probe, and you literally could remove that whole iris out of the eye if you're not careful. So it's one of those things that we must know about. Managing the underlying conditions before referral. So it's very important. Yes, you could be happy to refer. We're happy to take the patient, but make sure that the patient is controlled nicely and HbA1c is done, which reflects the control over the past 3 months, because we will do perfect surgery and the patient complicates with endophthalmitis. It has happened to us many times, and only to realize that because the sugar wasn't controlled. Other complications that can cause problems, high blood pressure, obvious, not necessarily cause, because now when you do certain procedure, you can have a risk of superior choroidal hemorrhage, which you can actually lose the entire globe because of a simple procedure like that. That's for mainly our problem as ophthalmologists. But anyway, it's worth mentioning here so that at least we remind ourselves as colleagues of some of the dangers of this process. Now, cataract surgery overview. The current standard procedure is phaco emulsification surgery, whereby we use ultrasound probe to remove the lens from. We don't remove the lens out of the eye, but we do the suctioning right within the eye itself, and we do we plant in a foldable lens that is through a small incision or corneal incision, and it unfolds into the bag, and we're able to solve the problem. There's other procedures like the small incision cataract surgery, which we do a lot in the campaigns for the blind, for the bureau. We do small incision cataract surgery. We put in a hard lens, PMMA lens, and it's normally a 1 day procedure. Very quick recovery. This phaco emulsification. We operate you today, tomorrow, or same time, not even tomorrow. Same time, especially phaco emulsification, if people are using the intracameral anesthesia or local anesthetic, the same time you can see, you know what I'm saying? That's how beautiful it is. It's a problem that can cause depression, and yet to solve it, it's a snap of, within 10 minutes, you could have solved that problem. Or maybe 10 minutes too short, maybe let's say 20 minutes, you would have solved the problem. Yes, some cases they go as quick as 7 minutes or 10 minutes, you know what I'm saying, based on experience and skill, So conclusion, early detection by colleagues can improve patients' outcomes. Very important. I've mentioned all the specialties. The general practitioner is right there, meets the patients always, all the time, prescribes different kinds of drugs. So it's very important as well that when a patient starts complaining of, not sometimes they don't really have to start complaining. People don't complain a lot. Ask them, is your vision okay? You know what I'm saying? Because all of us at a particular age, we start having problem with eyesight, whether it be presbyopia, or you know what I'm saying? So it's very important for these things. Apart from that, we also have other problems, dry eye disease, that also affect vision. So it's very important for us to really address these issues properly. And so there's other specialties. You don't be stuck or treating the bones, rheumatologies alone. You are there, you refer accordingly. I know the specialists, they know what they refer. Rheumatologists, they know, they must always worry about maybe vasculitis in the retina, but there's also the cataract that will develop. You know what I'm saying? So it's very important for us to be aware that the drugs that we're using could cause a problem, whether it be topical, or it be creams, whether it be this, can cause a problem. Now, I want to show you this video, just a small video. I hope you will be able to see it. I'm going to mention what's happening. You can see here, these are people, this was like 7 o'clock. We're in Tabazimbi for the South African National Council of the Blind. These are old people in our country who are blind. They've traveled from every place in the province of Limpopo, from Butlokwa, from Genfes, from others, from Elim, to get this service that the public sector can't seem to cope with, because also the ophthalmology specialists are not that many in the country to deal with not just cataracts, but also to deal with the rest of the problem. So you can see screening patients at night. This was a campaign that was aimed at doing about 200 of them in a week with two surgeons, changing one after the other. You know, this is serious work. Now, this is just some of the pictures you can appreciate. This is me on the right here. This is Dr. Sibomane that we sometimes operate with, and some of the colleagues that we, Mr. Bukotsi, Matibako, that we operate with using small things. Not, I don't think the actual equipment to address is that expensive. Yeah, I guess relative, but the benefit of what we're getting with doing this surgery, we are really helping. We are changing lives, not just changing them. I remember we're changing lives in terms of depression. I remember this one time, just as a small testimony, there was this other old lady from Guamshana. I was operating in Swane Hospital, and then she had Parkinson-like movements. You know, I don't know how I put her on the list. Now, when I put on the bed, her head was shaking. You know, you would need a stable head to really operate. And I said, no, hey, mommy, I can't operate you. I'm going to mess up your eye. She cried for me to say, no, Dr. Please, I beg you, please try. These kids, they leave me alone in the house. I don't even know, you know, I can't even hurt myself. You know what I'm saying? She begged. And by the grace of God, we prayed about it, at least in my heart. I prayed about it. I said, oh, Lord, please help me, help this lady. So the only time I could do the procedure is that every time she shaked less, I tried to do my movements. When she shook more, I stopped. And beautifully, the grace, the silver lining is that she had a malignant cataract, which is a soft cataract in the center. So I didn't really have to do a lot of manipulation. Put the lens, and the mother was so happy. I was looking for a video to show you that after we have done this cataract surgery in this population, the old ladies are singing songs. They are happy. You know, you would think of a song only limited only to the song, but you are changing lives. Now they can visit their people. They can see their grandfather or their friends. Now they can be left without worry that they will fall into the fire. You know what I'm saying? They can see their grandchildren. They can live longer, happier, no more depression. They can sleep. You know what I'm saying? There's a lot that we're doing in addressing cataracts. The backlog is serious in the country. And I have heard that Clinix is embarking on a campaign to try to also do their part in helping out this. It's beautiful, it's commendable, so we must do the same. I don't know how we're gonna work together with the government to be able to address this problem. You know, I must say that in the government sector, they truly are not spending enough resources in eyes. They just think that we are doctors who will just hold the direct ophthalmoscope look into your eye. There's a lot that goes into the eye. This organ, without it, you can't function. So it's very important for us, those who are in government, you are listening here, you must take this field very serious. Employ people to do this work. Create more posts for registrars to go there and study and become ophthalmologists. Stop the jealous. You know, I know when ophthalmologists are studying, the other registrars are jealous because we don't do heavy calls. But yeah, that is the benefit thereof of the specialty. It is hectic really to study into it because it's not your typical medicine. You know, right now, if I can sample anybody, cardiologist, and say, okay, here's an eye, what is this? They won't know because it's that super specialized in itself, because we hardly spend enough time at medical school. I think at most 2 weeks in it. So really, but nevertheless, here we find ourselves with a burden that all of us must come together as a country, as specialists, and work together and address it. There's a lot of skills that are sitting at home. Young people are having cataracts, are sitting at home, can't do anything because there are no resources. You know, so yes, that's the end of my presentation. These are my references, and thank you very much.
Thank you very much, Dr. Fakude, for a very inspiring and inspired presentation. I hope you can still hear me.
Yes, Dr. Kinoshi, I can see.
That's right. Yeah, I think that was amazing. One can feel the passion in your voice and the expertise as well. That you know what you're talking about, and that you've got your heart in it. And I like the way you present the clinical discipline of ophthalmology, that actually it is just as important as all other clinical disciplines, whether you're a urologist or orthopedic surgeon or whatever, what you do is quite important. And also, you mentioned how interrelated the specialties themselves are, the knowledge, but the systems, um, the physiology and pathophysiology that happens in the different clinical systems, that you could be giving a patient this particular medication as therapy and what it could be causing in other parts of the body. In your case, you talked about the effect on the eye from medication from other specialists, colleagues in other clinical disciplines. And I think that's something that I think all of us, it's a wake-up call for all of us in those who in different clinical specialists, that what you are doing, treating one organ could be having an adverse effect in another part of another organ of the same person. So you're not treating the organ, you're not treating a uterus, you're not treating the brain only in the case of neurologists and neurosurgeons, but you're treating a whole person. I think that's very important. It's a lesson, I think, for me. But I think, thank you very much. We have opened the chat box for questions and for people to post any questions or comment in the chat box, but we will also unmute anyone who raises his or her electronic hand if you want to speak and ask your question live. All you have to do is just to raise your hand. You go to, I think, React, because this is Zoom, and you choose, there will be a lot of things there, thumbs, and raise a hand, and then you raise your hand, and then we will come up, and I don't see them. You'll alert me as well, please. And thank you very much, Dr. Fakude. And maybe whilst we wait for more questions or people raising their hands for any comments, let me read the few that I have seen. A number have said what a wonderful presentation this is. And but there's one that that maybe I would like to start with. I'm just going to your question. Somebody says, is it possible to treat cataracts by drawing it by syringe? Never heard of it, but I think I've never practiced ophthalmology, as you know. Is it possible? And I think that's Dr. Mokhtar Belgrave. Is it possible to treat cataracts by drawing it by syringe or with a syringe, as we hear that it's sometimes done? Dr. Fakude, any comments from your side?
No, I think the simple answer would be no, you can't do that, because the procedure, pretty much how it works, is that it's a sterile procedure that you drape the eye. We normally will clean the eye with iodine. We'll do, if it's phacoemulsification surgery, we'll use an incision, about 3 incisions on the cornea. In as much as the cataract might liquid, the cortex, you still have a hard nucleus in there. So you will never find all liquid cataract. either way, you can't put a needle because how do you know how far you go? Because that's why we use microscopes to be able to see the depth, how deep you go in there. But nevertheless, it's a sterile procedure. Remember, there's also risks of endophthalmitis, which is in fact inflammation of the whole anterior and posterior spaces, and the patient can actually lose the eye. So yes, that's what I would say. Simple answer is no, unless if they want to modify the question if they are ophthalmologists. If that person is an ophthalmologist, then maybe they want to modify the question, but simple answer is no.
All right. Yeah. I think there's a question by Dr. Mutlante, Dr. Makala Mutlante. How do we prevent cataracts? I think you addressed a little bit about that, but will allow you to comment on it, cataract prevention. And if there's any prevention or preventive program, can this reduce the backlog? The question goes further, but maybe let me stop there for now and then I'll read the rest of the question. The question is about general practitioners. I think they say in the past, general practitioners used to do cataracts. Why can't GPs be trained on cataract surgery? Is it because of advance in technology in this field? What would be your comments, Doc?
Doctors, all what I would say is that okay, start with prevention. The only thing you can't, if we spoke of age-related cataracts, those are related to age. So now, if your cataracts related to the fact that you are aging, you can't prevent that from. You can't prevent yourself from aging. But what you could,
we all wish we could.
yes,
Yeah.
we could. But I would say definitely that the one thing we can do for ourselves is to do UV light exposure, reduce that. You wear sunglasses, because we can do that. We can eat a good diet, well-balanced diet, full of antioxidant, so that we can do for ourselves and live a healthy life. So those things will definitely contribute towards that, because you find old people over the age of 80 something who have no cataracts. Probably if you look into that, is their diet, their activity, and all that stuff. But if it's drug-related cataract, you can't prevent it, especially if you need the drug to solve another problem. So that's what I will say. Now, coming back to the question of GPs, we have a Dr. Sibomane. We will call him a general practitioner in Tonga Hospital. He's running the eye department. He's doing cataracts. We do cataracts with him. The 190 cataracts that we did in Tabazimbi 2 weeks ago, I was with him and Dr. Ngatana. Maybe the two of us were ophthalmologists, but I've always done cataract surgery with Dr. Sibomane. He's a general practitioner. He's in the space. He knows how to do it. GPs are able to do cataract surgery if they know how to do it. So they must spend time in doing it. The only problem would be the fact that it is a steep learning curve. But if you really want to do it, you can do it. Remember, even a general practitioner can do a craniotomy. You know what I'm saying. If there's subdural hemorrhage, and you are in Barberton Hospital, the general practitioner, they do that. And GP, the way GP general practitioners are, the structure in South Africa is that a general practitioner, as long as he knows how to to do the procedure, he can do it. So there's nothing that stops them. As far as I know, you can correct me, Dr. Kinoshi. So if you want to know how to do it, you can spend time in the space that performs it, and you can learn how to do it. Yes, equipment and theater availability, all those things, they can play a role. But I think the question is, can GP do it? Yes, they can do it. Are GPs doing it? Yes, they're doing it. We have lots of doctors, especially who are medical officers, because pretty much a general practitioner is a medical officer. And they are running departments. They are operating in Mankweng, in Tembisa Hospital, and different hospitals. They do that. So it can be done by general practitioners.
Okay. I think there's somebody, I think it says Swangile, but I couldn't get the surname. asking, can artificial lashes, what do you call them? Eyelashes, can they cause cataracts?
I'm not sure about artificial lashes, unless if during the planting of this, you are reacting now to the glue. You know what I'm saying? To the glue, and then that causes uveitis, etc., etc. Maybe in that way. But the only thing I would say is that we just as an interesting thing, as you were asking, as she's asking this question, because she's asking about these lashes. You know, simple answer, I don't think so. We haven't read anything about lashes causing a cataract. But if there's something in the glue that can induce the cataract, yes, in that way. But I haven't read about it. But what I want to mention that do you know that we have a condition called tattoo uveitis? That people who get tattoos, you know, they can get a uveitis because the body reacts to the pigment that is used during tattooing. And therefore, because of the uveitis that you get later on, then you can get a cataract that way. It was just something that was sparked by this question. But yeah, that's what I would say on that one.
Yeah, I think Dr. Victor asked another question. Why do some cataract operations fail?
Okay, this is a very loaded question. There could be a lot of reasons. First of all, we can talk about patient factors. The patient, maybe we failed to properly screen the patient. You know, maybe for diabetes. You know, it's uncontrolled. Therefore, we can have perfect surgery that has gone right, but you find that now the patient HbA1c is up there, and there's risk of infection, things like that. Or we failed on our side to pick up some infection around the eyelids, blepharitis, so that causes that. And so there's patient factors that maybe have pseudo exfoliation, as we've mentioned, the lens is loose and then the lens drops, or we remove the lens and put nothing. So I wouldn't call that also a failed surgery, because sometimes maybe patients are not informed properly. So that we just didn't put a lens. So the patient would need maybe a secondary procedure to implant the lens. So at least I'm talking about those facts for now. But we also have skill problem. The surgeon maybe is not skilled enough. He's taking chances. He's messing things up. He's not skilled enough. So in doing the procedure, it's causing problem, because that also can happen. Just like in any field, a less skilled surgeon is doing the procedure, then it complicates. You know, and sometimes complications do happen, just like we can walk on the street and be hit by a car. You know what I'm saying? This happens. So, but nevertheless, sometimes they don't go right because there could be patient factors. Patients are not using their drops. Sometimes maybe we do not tell them. Nobody is there to support the patient. And then in the end, the eyes, there's a lot of inflammation. No one is, because we do the procedure perfectly, and the people, the family goes away and says, all is done. They're not helping Gogo to put eye drops there and to have the problem. They don't follow up as well, another problem, to check, is there something happening? Well, things can change. You know what I'm saying? So there are many factors, unless if we're looking at a particular case and we can tell you, okay, in this case, it looks like this has happened. Yeah, so there's multifactorial in that way.
Yeah. And Tolakala, just assist me. There are two hands, but I can't see who has raised their hand. If you can call them out and unmute them, please.
Thank you. Thanks, Dr. Kinoshi. There's two hands, one from Lufuno Matiba. We'll take Lufuno first and then Moyeng Pito.
Okay. Thank you. You can go ahead and speak, Lufuno. Are they unmuted, Dr. Mtolisi?
Okay. My question is on the intraocular lenses. Once they're in, is it possible for them to... Can you hear me?
We can hear you
Yes,
clearly,
we can hear you.
Lufuno. Go ahead.
The,
Thanks.
the intraocular lenses, once they're inserted, is it possible for them to get clouded and kind of obscure the vision? And if that happens, what options are there available to actually correct that, especially
Okay.
in diabetic patients?
Okay, so because remember when we do cataract surgery, we're just removing the lens fibers. We leave the capsule intact. It's like a bag that we leave in there. So when we put the lens in the bag, it's possible for the bag itself to become white. It's almost like now you are getting a cataract again. So what we could do with that, we can do what we call a YAG laser. YAG laser, where we just give shots of laser photo disruption, and we can open the visual pathway so light can come in through. So I think that answers your question. We can do it that way, or in another different case where maybe patient also has a retina problem, we can do also intraocular way. We call it surgical capsulotomy. So this was laser capsulotomy, where we can actually cut the capsule behind with the vitractor. Yes, so definitely the capsule, not the lens. If these are proper lenses, they are not gonna become cloud because these are plastic silicone lens, so they don't get cloudy. But the capsule behind the lens becomes white, like we're getting the cataract again. So that is all simple by laser or surgical capsulotomy. Thank you.
Are you answered?
Simple, you must go see
Dr. Moyeng,
an ophthalmologist to assess properly what's happening.
Okay, I hope Lufuno is answered. I think let's get a second question.
Dr. Moyeng, over to you.
Dr. Muyeng, you can go ahead and ask your questions or your comment.
Yeah. Hello. Can you hear me?
Oh, it's Dr. Pitswe. Okay, go ahead, Dr. Pitswe.
Yes.
Yes, you
Dr.
can go ahead.
Fakude. Yeah,
Yes.
Dr. Fakude, thank you so much for a very informative talk. I think part of why this is so informative is that ophthalmology as a subject is a very neglected subject at medical school. So we don't never get to learn the relations that go between ophthalmology and everything else outside of the eye. And I think it's, from what you've just said, it's a scary feeling. It makes one look like being alive on its own is a big risk. And in fact, that if you're our age and you haven't got cataracts, you're a very lucky person, or you have it and it hasn't been diagnosed. But I want to ask two questions. And the first one is, why do you think it is that we do not see more cataracts in boxers and other full contact sports people? And number two is, and I know you spoke about increasing the number of registrars, but the numbers are very stark and the backlogs are very high. Is there a deliberate plan to increase the number of eye health practitioners, from nurses, optometrists, general practitioners to ophthalmologists? Thank you.
Very good question. Go ahead, Dr. Fakude.
Yes. I think the first question, contact sports and cataract, So which contact sports are we talking about? They could be, so, and also these are young people that are doing these contact sports. Most of the time, the young ones, their systems are still fresh, they're able to heal. But remember, as I said, cataract doesn't necessarily develop at the point of contact. It can develop 5 years later. It could be that by the time that they've left that sport, now later on, when you don't know about them, they start developing it. Or at some point, these same people that we are speaking about will develop this cataract. But it's not a fast rule that they must have the cataract. What I'm saying. And also how much did the impact, actually, maybe that's probably how I should approach it. Did the impact happen to the eye itself? That's very important, because you need contact with the eye that the lens itself is affected. That's one. Now, the other question concerning staffing, it's interesting that the government currently, my feeling is that if they are thinking of adjust, like to cut funding, they are thinking of cutting the ophthalmologist because they are of the idea that the ophthalmologist doesn't have work, So I know the medical officer in Tembisa does not even do overtime because they feel that if they put him on overtime, there is hardly any eye cases. So they don't pay for his overtime because of that. And the departments, at least in the teaching hospitals, at least they are well funded, but in terms of equipment, but in terms of post, there's a lack there because you find that clinics are buzzing with numbers over 60 to 90 or even more, especially in Steve Biko, whereby there's a specialist. Steve Biko is a specialist hospital where we're dealing with complicated eye cases, which needs time, equipment, and skill. And we only have, I think, about 4 registrar posts there, saving only 1 medical officer post. Even that has happened recently because they converted a previous reg post into an MO post. So I don't think the government is interested. Maybe they can tell us if they're here to create more posts, because I know right now there's Dr. Vilagazi, there's Dr. Melabone, there's another doctor in Mamelodi. They are registrars with primaries, intermediates, and diplomas, and even started the research. They are waiting for registrar post. They are already cutting and no post for them to start their thing. And the government, the only interested is to look good. How many cataracts we've done? How many, you know what I'm saying? And to take pictures when people are happy, when they, the old people who have bilateral dense cataracts can see now they're happy and joyous, then they want that kind of thing. But like, okay, give me an example. Tembisa Hospital I've left there like about more than 10 years ago. They still don't have an OCT machine. You know what I'm saying, which is a machine that's like a scan of the back of the eye, which is quite essential. That means they are unable to do Avastin injections into the eye. Their patients are sent all the way from Tembisa to Steve Biko. So patients are wasting a lot of money traveling to another place when this service could be provided there. They could easily bring, even phacoemulsification is not done in Tembisa, which is the latest. You know what I'm saying? So anyway, because I speak for the ophthalmologist, I speak for the patient. So I feel that the government is not keen, at least in the regional hospitals, that could really help the system. So now we find Steve Biko being burdened with a lot of patients because other hospitals are not properly staffed. We're not properly staffed because there are no posts to train more specialists. And also, there's also now even a more serious burden because, because patients, also because of the environment of no proper machines, specialists don't want to stay there. Why must I, after learning such serious skills, go back to a place where I'm just going to be using a knife when I could be using a bazooka? You know what I'm saying? To deal with issues. Now you give me a knife to go and dig a hole when I could be using proper machines. So the government is not interested in I don't know. That's the impression I'm getting. And it's frustrating because our people in the country are suffering and are dying blind unnecessarily because maybe those who are in leadership, maybe they are the wrong people to lead there, because ophthalmology, I can tell you for sure, Doc, that they really are. We are there, the cornermen of serious people. Only when there's time for October, they want cataract marathon numbers. Now they speak about it, but they don't invest in the space in the field. Thank you.
Thank you very much, Dr. Fakude. I can hear the passion in your voice, and also I'm impressed with your participation in the outreach programs that you shared with us to Tabazimbi, Sukukuni, and many other places. And I hope more and more of our specialists, even in other clinical disciplines, could also do that as well. Well, in the Minister of Finance budget proposal yesterday, one of the things he mentioned was some additional conditional funding. I hope it is conditional for appointment of health specialists, including doctors. So let's hope that money will be used to hire not just the post-concept doctors, but also more registrars in all specialties throughout the country as well. I'm sure this will happen. But talking about the issue of staffing and constraints, I'm just thinking about the intraocular lens that is inserted during cataracts operations, Dr. Fakude, that you told us about. First of all, are there different qualities of these intraocular lenses? And if so, in the state, are we using good quality intraocular lenses? And I hope you'll assure us of that, because you spoke about many other constraints. I hope we don't have a constraint in buying good quality lenses if there are different qualities of lenses on the market. What would be your comment?
Yes, Doc. There's definitely qualities of lenses, and in the States, if we do phacoemulsifications, they do order foldable lenses, which are I would say, of good quality. But that's as far as it goes. Only those types. So we don't do more fancy lenses like EDOF lenses, which are extended depth of focus, which are lenses that give you an extended range of vision from nearsightedness to distance vision. Those are more expensive lenses. I think in the government sector, you must forget you can't get such a lens. They're just too expensive for the government, I would say, to afford. So they just afford the basic one, like a three-piece lens, like Alcon lenses and other companies. This is like tenders that are given to a particular company, so maybe to give discount. But I think when you do phacoemulsification, I would say those lenses are good quality. When it comes also to small incision cataract surgery, which are more rigid lenses, I think they're acceptable lenses. I don't think there's low quality. Those are good quality lenses. We put them. We've never had anybody look at the study. There could be studies that I'm not aware of, but I would say those are good lenses. And also, there have countries that produce massive volumes of these lenses, like India. They have a huge population, so it's also good to know where to order them. I think there's that. But though there is a tendency as well to cut corners and get poor lenses. So far, to my experience, the lenses that we're using, they're okay. They could be other lenses that are bad. Actually, they are lenses sometimes when you use them, they snap and break the haptics. So I'm not sure whether I would say those are the poor quality, but so far in my hands, the lenses are okay, and we don't have any issues with that. I think that's what I would say on that question, Dr. Kinoshi.
Yeah, that's right. And I think having said that, we are aware of the massive load. I mean, you've mentioned in your first or second slide the numbers of people waiting to have interventions for cataracts in the different areas. So the load is quite big, and obviously, probably we don't necessarily need to have the best lens in the world for all those millions of people, but at least ones that are of good quality. And I'm glad you assured us that the quality of the quality of the lenses that we use in the private sector, in the public sector. Dr. Motlanthe goes on to ask another question. Objects moving in front of eyes in the dark, and this looks like lightning. Can this be related to cataracts or retinal problems?
Yeah, I think it's very important for us to really assess properly that question. But nevertheless, if it's asking about floaters, like when you're in the dark because of the, how dark is the dark? Is it pressing his eye, or you know what I'm saying? I want to know, because sometimes when you press on your eye, you can see some flashing sometimes because you're pressing on the
Exactly.
net layer.
Exactly.
So I hope he's not doing that. But nevertheless,
maybe Dr. Motlanthe can unmute and explain his question, Dr. Motlanthe, and explain it to Dr. Fakude so that he can answer you appropriately. Oh, Dr. Mtlante is not unmuting. You can go on, Dr. Fakude.
Oh yes, I was saying, so floaters is something that happens, nevertheless, something that happens when there's vitreous changes at the back of the eye. So this is now behind the lens. So as we age, this happens. So you can, if you look at yourself, sometimes most of us, if you look, you will see that there's something like moving a little bit. Those are called them floaters, so those are moving objects. So that's that. But flashing of light, flashes of light, normally with the loss of vision or visual field, that those are associated with the retinal detachment. And that is something that I think maybe that's not what is asking, because someone with flash of light and suddenly they lose vision, they will know it's an emergency, so they'll probably have to go and consult because the retina has detached it's almost like now when you look at the plug, it's not properly connected. There's a spark of lightning, spark of electricity. That's what happens in retinal detachment, so you can lose a quadrant or whatsoever. So I think maybe was asking about floaters, which are just, unless if they bother the person, and if they really bother them, they can do vitrectomy surgery. But most of the time they don't bother, they are not a problem. You can live with that and doesn't affect your vision, etc. in your function.
Yeah, I think we're going towards the end of our talk, but I think there are just a few other questions that I think maybe we can clear, Dr. Fakude. Dr. Sanelisiwe Mweli says, my son complains of not seeing, sorry. My son complains of not seeing a thing in the middle of the day. What could be the problem? Should I be worried? And he says he's only 2 years old. So the 2-year-old who says during the middle of the day he can't see anything. We don't know whether it's related to the fact that maybe he looks into the sun or whatever. But maybe your comment on that question.
Yes, we need to know the circumstance of this. Maybe he has closed his eyes and he says he can't see. You know what I'm saying? So children are very are very creative. So maybe if is the child saying I can't see while the mother is present, or the child is reporting they can't see because it's something that happened when they were away. You know what I'm saying? Those are the question. But nevertheless, if it's something that's happening often, that the child says that, rather consult, because we also have what we call functional visual loss. You know what I'm saying? When you say the child can't see, it would be important for you to take the child during that episode and to an ophthalmologist to check exactly because it's impossible for the child not to see now and later on the child can see again. You see what I'm saying? That doesn't make sense to us. Obviously you've mentioned a good point. The child must not look into the sun, because that later on can cause solar retinopathy, can damage the back of the eye because of the massive UV light that goes onto the macula. Child must not do that. At least the mother can advise, don't look at the sun. At least we can say that for now.
Yeah, there's one question which was asked by fellow attendees in the chat. There was somebody who was asking, what can be the pale to blue lining surrounding the lens? What does it indicate? And others, people have responded to it saying it could be acus senilis. And they could be right. Do you agree, Dr. Fakude?
Yes, acus senilis.
Yeah, due to age.
Old age, the position of cholesterol in that area. Oh, yes. As you age, you get this line. It's normal.
Yeah. Okay.
But it also could be a sign of high cholesterol, doc. So probably you need to go see your GP. They do your cholesterol test to check if you don't have high cholesterol.
Yeah. Yeah. Well, a lot of other postings are just throwing praise for your presentation, Doctor. Very enlightening, and I think people are very happy. There's a question. I don't know whether it's the last one. I think it's from Dr. Pizzo. If you come 60 without, yeah, I think he did say that, he did unmute and say that. I think that's what he said in his when he spoke, so maybe I'll skip that unless if I'm missing anything. I think that was the last question, unless if I've missed anything, Kalakele, you on your side, and Dr. Policy, you'll alert me. But I just want to.
There's one hand there.
There's one question, Dr. Fakude, from Dr. Monica Makai. Why use intravitreal corticosteroid implants for diabetes macular edema and AMD to achieve dying of the eye while you are increasing the risk of cataract?
Oh yes. Oh yeah. Remember when we use intravitreal implant because steroid is because we are addressing a problem, which is macular edema. And it could be that an ophthalmologist has tried to use anti-VEGFs in that eye, or maybe you know what I'm saying. So the swollen macula could be caused by inflammation or leaking blood vessels in that area. So we use the steroids not because we want to, but because the patient can't see the macula is swollen and all they can see is counting fingers. So when we use the steroids, vision improves to 6/6 or to better vision. The cataract is a small side effect because we can remove the cataract if it develops. But a patient who can't see is not a happy patient. So we use the steroid because we are solving a problem. It's the same thing when you have a flare-up of SLE, whereby you must halt the inflammation by the steroids. But we must know that it can cause a complication of cataract. But nevertheless, cataracts are easy to solve by cataract surgery. So it's one of those things that if we don't do these things, continue to worsen. So that's how I'll address the question to the doctor.
Yeah. Okay. Dr. Faith, Matibane asks, does the private or do the private and public sectors have different criteria on when to remove a cataract? Are there different criteria in the private sector and in the public sector on when to do cataract surgery on a patient?
No, there should not be different criteria. It's just that in public, people have funds, so we're able to intervene as quick as possible. In the government sector, there's 4,500 people waiting in Mankweng. You see, you might have a cataract that bothers you now, but you jump into the waiting list, not because we want to put you there, but we just can't get to you now. So the criteria is the same. If you come to us, you have a cataract, is affecting you, we must take it out. That's the criteria. If it affects the patient, that the patient can function well, we can see there's a cataract, we need to remove it. That's the criteria. It's as simple as that. In government, yes, takes longer to address it, not because we want to take long. We are itching to remove the cataract. It's just that the resources, the numbers. If there's 1,000 patients who are bilaterally blind in both eyes, you only one eye, I'm certain that we will put you right at the back of the list. We'll address those who can't see a thing. You know what I'm saying? It's triage system in that sense. So I think that's as simple as that. Thank you.
Dr. Matavani also goes on to ask, how do ophthalmologists decide on the type of intraocular lens that they will be inserting in a patient? And kindly summarize the differences.
Okay, now.
I think in a way you asked it when you responded partly to it when you were answering my question about the quality of intraocular lenses used in the public sector and the private sector. But how do we decide on which one to use in a particular patient?
Now, let's say this is a private paying patient, and this patient is he is well off. He is able to afford any lens. He's able to pay an extra amount for anything, and we tell him, okay, this is it's a lens. It will give you extended vision. You can see, you can see, you can read, you can also drive very well. So this lens for you to get it is 20,000, and we say to you, it's because you don't really have to use glasses when you put this lens. Whereas if we put a monofocal lens, which means it only has one focal point, That means either you will drive with the lens without glasses, or you'll have to use glasses to read. That's a very cheap lens because it's monofocal. So multifocal lenses, they give you many focal points of vision based on whatever is desired by the patient, and also if the patient can afford it. So those are part of the things. And also you have toric lenses as well, if patient have astigmatism. But those are also more lenses, that cost more, because now we're putting a sphere and a cylinder in the same lens, that kind of thing. That's one space. In the public sector, most of the time, toric lenses might not be there. Most what is available is monofocal lenses that are foldable, and also hard lenses which cater for massive population, that the aging population, and also people can afford, and quick, simple procedure. What is available? Like in Tembisa Hospital, they don't have a phaco machine, so forget about getting a foldable lens. EDOF lens, for EDOF lens, I don't think they're anywhere in the public sector. So you can't get any of those lenses foldable or EDOF in Tembisa, because the only procedure they do is small incision, cataract surgery, and it only gives hard lenses. So that's how we decide. In public, in the private sector, we discuss with you, we tell you what is the outcome of that lens. The lens is designed to give you these results. And if you're well able to because the medical aids will only pay a certain portion. If you want, if they pay for a BMW and you want something that performs like a Ferrari, you must cough in the difference. That's pretty much how we decide. Thank you. I hope that helps to some degree.
Yeah, Dr. Thabo Mashego is asking whether any type of glaucoma can lead to cataract formation.
Yes.
And what will be the management thereof and the approach?
Yes, we've mentioned in the presentation that trabeculotomy can cause the cataract, actually. And also putting devices, mixed small minimum invasion glaucoma devices can cause a cataract. And once the cataract is formed, the only approach is to go back and get the cataract removed and put a lens there.
Okay. Yeah, I don't see any other questions that you may not have responded to partially. I think if we go on with all the questions, we can go on whole night. But I think it just shows how interesting the eye can be, and the topic that we're talking about, and how common this problem is. Dr. Fakude, and I wish we could go on forever, but obviously we can't, because normally we schedule these to last 90 minutes. Otherwise, attention span of attendees decreases with time. So those whose questions we may not have addressed, or who are still going to ask questions, I think they're free to write and then we will pass them on to Dr. Fakude, and for Dr. Fakude to respond to them on your email address. So I think you've got our email address, and unless if Dr. Fakude, you want to give your email address, but we can do it through us. People can post more and more questions to yourself. Is that fine with you, Dr. Fakude?
Yes, that's fine with me, though.
That's right. I think what remains for me, first of all, I need to remind everyone that next week, the 20th, next week, Thursday, the 20th, we will not have a webinar. And I think this is because, it's long weekend eve, if I may put it that way. And next week, Friday, the 21st, is Human Rights Day. And so we find that when we have a webinar on a day like that, people are traveling, and it becomes problematic. So we have consciously decided not to have a webinar next week, the 20th, but we will have a scheduled one, and you'll all be notified the following week, Thursday, the 27th. I'm going to hand over to our group medical officer, Dr. Mxolisi, to be able to do the closing. First of all, to thank the speaker and everyone, the team behind in the technology, but also to close the webinar, Dr. Mxolisi, so I won't come back after this. Over to you, Doc.
Thank you, Dr. Kinoshi. It is my pleasure and honor to have a word of thanks on behalf of Clinix Health Group. And thanks to Dr. Fakude for a comprehensive and informative presentation on cataract. A big round of applause, Dr. Fakude. And also, I'd like to thank the participants for their continuous support and participation in these webinars. And lastly, the marketing team in the background for their support during the webinars. I'm looking forward to meet all of you on the 27th of March. Same time, same place. Have yourself a great evening and goodbye.
Thank you very much.